the beginning of the beginning for us as people living with HIV. Nokuthi ke hey saphinde sibonane siqhawulane kade sagcinana asisati nalabanye ukuthi babhaca ngakuphi kepha namhla siphinde sibonane. It's honestly a very good space ukuthi siphinde sibe kanye kanye and seeing people abasikhulisile mina nje nabo sendenjani bangikhulisa ngemntwi ngisagcoka nabo size 26 bukanye nabo sengagcoka size 36 uyabona ukuthi hayi le ndlela iyahambeka. So ngiyacela nje ukuthi sihambise on the table usho ukuthi ungubani wakabani and then we'll then give to Supercharger to take over as indicated the first presentation of the day.
Hello guys, my name is Willem Lambo. Hello guys, my name is Willem Lambo.
Sanibonani, gama lami ngikhosi ngokadlamini. Hi everyone, gama lami ngikhosi ngokadlamini ngisuka FAView emakholweni.
Sanibonani, ligama lami nguSiphiwe Dlamini.
Sanibonani, gama lami ngingisende njani ngwakamasi.
Ngiyanivusela nami uJohn wakaMoraish.
Sanivusela bekunene Vusi Ncumalo.
Hello, ngingilulu ngwakavlakati.
Greetings everyone. Happiness Mabuza is my name. Thank you.
Sanibonani, igama lami ngingiphathwa kahle Dlamini suka FAView.
Sanibonani, igama lami ngingibali wamagagula ngisuka ekwaluseni inkundla.
Sanibonani, igama lami ngingKevin Kumalo ngisuka eMalkans.
Sanibonani, igama lami ngiSibongile Mnisi ngisuka eMochane.
Sanibonani, igama lami ngingilungile Nyasulu Mangayane.
Sanibonani, igama lami ngingDanele Dlamini ngisuka eMbolonjeni.
Sanibonani, ngingimodel Singoka Dlamini ngisuka ekwaluseni.
Sanibonani, igama lami ngumcebo ngakadlamini ngisuka FAView.
Viva comrades. My name is Bonisile Mamba from Timbutini.
Sanibonani, Khayisile Ncumalo suka Lakamanzini.
Sanibonani, Bumelelo Dlamini eShiselweni.
Sanibonani, Minkisithole ngisuka eDvokodweni inkundla Newtulon.
Siyabonga kakhulu comrades and ngicabanga sithathola ithuba lethi sicoce sesike futhi sithi nekuhlabela ingoma tethu ngosami temzabalazo la sibuya khona mase ngiyabona nalobuso. Supercharger, thank you so much for bearing with us. We can give the floor to you and we are certain that you are going to give us your best like you did yesterday. So we take notes, we keep the questions that we are going to have for Supercharger so that at the end of their presentation then we can ask them certain questions. Can we honestly have an interactive discussion after this presentation? Over to you, Supercharger.
Yes, I'm called Moses Supercharger. I live in Uganda. And I'm a person who has been living with HIV since 1994, openly and positively living with HIV. I'm really happy to share the little I know with you, my friends. And I feel very sorry I couldn't be there in person, but I expect next time to be there. I also want to see your beautiful country. Today, I'm gonna discuss with you this important topic called the HIV cure. What is the HIV cure? Why do we want an HIV cure? How do we and your role as an advocate for this HIV cure? We all know that ever since the discovery of the HIV virus, 70 million people have been infected with this virus. 70 million people have been infected. And over 35 million people have died because of this virus. And as we speak now, 38 million people are globally living with HIV. 38 million people are now living with HIV. So it is a big problem which must be solved. Several steps have been taken to solve this problem, and it still persists. There is treatment, there is prevention tools, but we still see new infections, and we see people are still dying. Therefore, we need an HIV cure. What is this cure that we are talking about? As an advocate, step number one, you must understand this cure. When they say HIV cure, you must have a clear community definition of what this cure means. What is an HIV cure? We define the HIV cure in two ways. One, eradication cure. This is the medicine that can be given to a person living with HIV, and it completely removes the HIV virus from your body. Completely. You don't remain with any virus. Completely, you are cured. Nothing, no virus. So that is called eradication cure. Or you can have what they call a functional cure. In our community language in Uganda, I call it a freezer cure. This is the medicine or an intervention that can be given to a person living with HIV, and it freezes this virus in your body so that you don't need ARVs every day, so that the viral load does not go up and you cannot infect your partner or your baby. So when we define HIV cure, we define it in two ways: eradication and functional cure or freezer cure in a community language. I repeat, the eradication is total removal of the virus from your body completely. Nothing remains. When they test, they don't see the virus. And you don't infect others. You don't need ARVs. Or functional cure or freezer cure in our community language, whereby this medicine, when it's given to you, it will freeze the virus in your body. It will not produce more viruses. You will not infect others because the viral load is not going up. You don't need ARVs every day like I do, because I depend on ARVs every day. So we have finished the definition. Why do we want this HIV cure? We already have ARVs, which we take every day, and we look beautiful and nice, like you see. I'm very good looking, I'm very handsome, I'm very healthy, simply because I depend on ARVs every day. Somebody will ask you a question, okay, if Supercharger has ARVs, why do you waste time in finding an HIV cure? Let him just take the ARVs every day. So you must have answers and say, oh, Supercharger has ARVs, but there are problems. He has problems. Problem number one, taking these medications every day is a problem to him. And the 38 million adherence of this medication has always been a challenge. That's why we are seeing people failing treatment and being switched to other lines, complicated and most expensive lines, because the adherence is not easy. Taking these medications every day is not easy. We have children born with HIV, and we expect them to take medication for so many years. Remember, we don't tell them they will take medication the rest of their lives. No. As a cure champion, you say, take medication until cure is found. Take medication until we find a cure. You don't say you're going to take medication the rest of your life. That is very discouraging. So we need a cure because of adherence issues. These medications are not sweet. They are sour. Right now, I'm away from home. I forgot my medications, and I had to hire a cab to go back, a lot of money to go and pick my medication to come up country where I am. So all those challenges, if there is a cure, I wouldn't have those challenges. You just go, you take that medication once, and you are functionally cured or totally eradicated the virus in your body. So that's reason number one why we should advocate for an HIV cure. The second reason why we want an HIV cure is because of the cost of the medication that we are taking every day. These medications we take every day, the ARVs, are very expensive. And in Africa, we depend on Europeans and Americans to buy these medications for us. They are just donating these medications for us. If they get problems and say no more funding to Africa, we shall all be dead. Because as we speak, our countries cannot buy these medications for us. I'll give you an example. Uganda, my country, we get $400 million every day from America to buy ARVs for us, Ugandans only. And yet America buys medication for almost every African country. One day, if America says no more funding, we have our problems, we want to put this money into our problem, into our infrastructure, or we want to divert this money to Ukraine war, we shall all be dead. Therefore, we must look for an HIV cure. Just in case that happens, we have an alternative for us to survive. People have run out of treatment options, you know very well. In my country, we have people who are on third line. You fail first line, you are switched to the second line. You fail second line, you are switched to the third line. And we don't have a fourth line. The question is, what will happen to these people on the third line? Because we don't have fourth line. If it fails, they are going to die. Therefore, we must look for an HIV cure to save these people. And majority of them are young people. Young people face a lot of adherence challenges. Why do we want an HIV cure? Access. That's another reason why we should advocate for access. Remember, there was confusion and turbulence in South Africa some time back. Shops closed, hospitals closed, and people cannot access these medications. Somebody cannot move away from his home to go to the hospital and pick the medication. There is war in Congo, there is war in Sudan, war in Somalia, and there are people living with HIV. How do they travel to the hospitals to pick the medications? The hospitals are far away. They need a lot of money, transport to pick the medications. So access is a big challenge. If there was a cure for HIV, all those problems would have been. Another reason why you should advocate for HIV cure is stigma. So many people are being stigmatized, denied good opportunities because they are just HIV positive. 15 years ago, I was refused to marry the person I loved so much just because I was HIV positive. They said, you can't marry our child, the parents. But why are they stigmatizing us? Why are they denying us opportunities? Why are they refusing us to marry the people we love? Why are they refusing us good jobs? Why are they denying us visas? It's because we are HIV positive and they think we have no future. I give you a visa, you come to my country, you'll die next month, and then I will start having problems of where to bury you, how to take you back. You fall sick in my country, then another cost of buying you medications, no visa. But if there was a cure, all those problems would have been solved. Because people with malaria are not denied visas. Because they know even if you fall sick, you'll take a medication there and get cured. So we must advocate for an HIV cure. The cure is very important. People are still dying. Despite the fact that we have the ARVs, people are still dying. New infections are still occurring. UNAIDS reported that last year we had 1.5 million people infected with HIV. If there was cure, this problem wouldn't have happened. Okay. What is the role of you, my friend, as an advocate? An advocate for this important tool, the HIV cure. What should be your role? Your role, number one, is to love this agenda, the cure agenda. Love it with all your heart and support it. Number two, You must understand this agenda, the cure agenda. Everything, because you will be asked by your fellow community people, what is this cure? Why should we push for an HIV cure? You must have answers. So you must learn all components of HIV cure. Then after learning all components of HIV cure, you must translate what you have learned to other people so that they can also translate it to other people. Are we together? Role number 3, you must advocate for the introduction of these trials in your country. You must fight to see that such is brought to your country. Such is in America and European countries. And yet majority of people with HIV are in Africa. 38 million people living with HIV, 20 million are in Africa. One continent carries 20 million people, and yet we have 6 or 7 continents. So the biggest burden is in one continent, Africa. That's where research should be. But research is the countries. What is another role? Another role, you must be very careful when you are advocating for this cure research. When it is brought into your country, make sure it is carried out on good participatory practices. It must be carried out on ethics of research. You must make sure that participants are protected. In other words, you must make sure that there is safety of all people participating in the research. Encourage inclusion of all people, key population groups, the trans people, sex workers, MSM. Let everybody who wants to participate, and make sure they are safe in clinical trials. Yes. The inclusion I've talked about is really very, very important. Now, what are the tricks of understanding this cure agenda? This cure agenda, the language the researchers use and the doctors use is really very complicated, very hard to understand. What are those tricks that can help you understand this complicated agenda? First and foremost, you must get involved, even if it's hard. You must listen. You must attend all cure-related presentations and keep asking questions. Attend. It took me about 5 years to understand this cure agenda. 5 years. All years I was attending sessions and I was like, oh, what is this? They have talked about what? A receptor, CD4 complicated receptor. What? I couldn't understand until I began breaking them down slowly in my community language. I'll give you an example, a very simple example. When HIV enters your body, its main goal, what it wants is to enter a CD4 cell, your white blood cells. That's what it's looking for. For HIV to survive, it must look for that white blood cell, attack it, enter it, and start production of more HIV. So without your white blood cell, this virus cannot produce, this virus cannot cause trouble. So researchers are saying, oh, if that is the problem, so the cure is around this important component, which is the CD4 cell, the white blood cell. You will realize there are several methods they are using to cure HIV. One of the methods that they are using to cure HIV is to prevent this virus from entering your white blood cells. You are given medications or you are given broadly neutralizing antibodies so that the HIV cannot enter. Or if it has already entered, you can be given this medication that can prevent it from producing more HIV inside your cell. So, researchers sat down and said, oh, somebody gets infected today and then starts falling sick after 2 years. What is protecting him for 2 years? They realized what is protecting him is his immune system, the white blood cells. The white blood cells fight HIV for some time, but they reach a time and they are overpowered. If that is the case, then why don't we just aim these white blood cells periodically? Every after 2 years, we give you an injection, we give you a tablet, which pushes, which energizes, which engineers these white blood cells so that they can continue fighting this HIV, and you don't need medications. So those are some of the things they are doing. Another thing, you can never understand the cure agenda without understanding the life cycle of HIV. That is really very important. Try as many times to understand the life cycle of HIV. When you understand the life cycle of HIV, understanding this science will really be very, very, very easy for you. Will really be very easy. Another thing, keep attending all international meetings, apply for scholarships, network with organizations that are doing advocacy in cure research. Organizations like Caring Cross, HCAAP, AVAC, GGTI, all of them, get in touch. Apply for scholarships. Right now, the scholarship to attend the IAS conference, scientific conference in Australia, are closing in 3 days from now. Have you applied? You haven't applied? Please try to apply. And if you fail, keep trying. I apply many meetings, but it's not that all the meetings that I apply, that I get them. No, so many meetings actually fail. Keep applying and don't lose hope. I will stop there and then I'll take some questions. I'll be very happy to answer at least 5 questions before I leave. Thank you, dear.
Thank you, Supercharger. I will look into the room if there's anyone with a question. Yes, there's a question already. Ngathi kutofuna ubuya lamzana.
All right. Thank you so much, Brother Supercharger, for the presentation on the cure. I want to applaud the initiative to look into the issue of the cure for HIV, because we had relaxed and thought ARVs would continue with us for a long time. But then the comment I have, I don't know whether it's in the form of a question or what, is when you said, why do we need
she's breaking, I can't hear.
Oh. All right, can you hear me now?
Yeah.
All right. I first started by saying thank you very much for the presentation. we had stayed so much with the ARVs for a long time without looking into issues of the cure. So we welcome the advocacy around issues of the cure. Then I said I have a comment regarding why we need a cure. You can hear me?
Yep.
Okay. All right. The comment I have is you mentioned that there are issues of adherence, treatment fatigue, all this and that. Those are some of the reasons why we need a cure. But one thing I think we need to also explore is once you've taken the ARVs for a long time, what are the negative effects? What are the diseases that we might have when we have taken these ARVs for a long time, which is what I think is why we also need a cure. And then there is this other issue you said that we are being assisted by countries from Europe to buy these ARVs. So this one is not a question to you only, but it is a question to all of us living with the HIV in the country as well. And we're seeing that this as a capitalist agenda. I don't know whether you understand me, but an agenda which says we should keep on enriching those who are giving us the ARVs, because now it is a business. We want to get well, but then the European countries have seen it as a business, because I know as much as they give it to us, but there is some money that they use. Thank you.
Did you get that supercharger?
I didn't get the last one, but I just got the first one, that people have taken medication for a long time. And I agree with her. Like me, I've taken medications for 30 years. And I want to live another 70 years from now. But the challenge is that, will these medications, will my internal organs tolerate this medication for another 50 years? So it is true, we want an HIV because of toxicity of these medications, because as we take them for a long time, maybe our internal organs get a point and defeated. So I totally agree with her, but I didn't get the other question she was breaking. Maybe the position where she was. You can help me to break it down, the question.
Oh, okay, it was more of a comment that the medication that we have, especially here in the country, it is.
I agree with that.
The medication is bought by international partners or countries. So the biggest challenge is that nothing comes to Africa. So as much as they give us donor funds, but still the money goes back to them. She mentioned that it's more of a capitalist agenda. It was more of a comment than a question.
Okay. Okay, thank you.
We have the second question.
I'll be happy to take at least 5 questions, because if I don't get questions, I get worried that maybe people didn't understand.
Here is the question, Supercharger. There's somebody to ask you another question.
Great.
Good morning, everyone. Can you hear me, Mr. Supercharger? Moses?
No, I can't hear him, but I hear you very clearly. I don't know why.
Huh? Yes, can you hear me? So
yes,
there's a statement that you made before your presentation. I think I love it. You said take medication until we find cure. That was a good statement. My question is, as much as we advocating about HIV cure, we should remember most of the medication we have, we depend from donors. Then as much as we are advocating about HIV cure, as African, what are we doing? Because I feel like as African, we can do the research, because everything we are doing when it comes to HIV, we are depending from donors. What research have we done? For example, you said like 20 million people living with HIV, they are from Africa. It's a huge number. So what are we doing about that? Because the European or the donors, they can decide today to drop. But we are always opening a hand to receive something. What are we doing as African? So as much as we are talking about HIV cure, we should also encourage people living with HIV to adhere on treatment, because we'll start talking about HIV cure and people, they will be reckless, thinking that we'll find the HIV cure tomorrow. So this should go as a package. We motivate, we advocate. Thank you, Mr.
Were you able to get that supercharger?
Yeah, you can read it for me. I heard the first line. He said that I made a statement that people should take medication until there is a cure. But then I stopped there. Can you please summarize the question for me?
It was also more of a comment where he was saying the question that he has is, what are we doing in Africa in terms of the research? Because instead of us depending from donors, but we need to develop our own research that speaks to us as Africans in terms of HIV cure.
Yeah, I agree with him. I entirely agree with him. And that's why they are here. That's why we are here. And that's why you are there right now. The main reason why you are there is to going on around the world so that you can advocate for it in your country. You stand in front of the Ministry of Research in your country and ask him, what are we doing in the field of research for an HIV cure? In America, they are doing it. 7 people have now been cured of HIV in America. But we have not had any African person being cured of HIV. Research is going on, but my country is not participating. So that's why you are there, to learn what's going on around the world and advocate for it. You advocate for it by asking your government, by asking the international funders of research like NIH to bring the research to your country. Because that's where the majority of the problem is, Africa. But research is in America. And my statement, which I said, in my country, I advocate not to tell people to take medications for the rest of their life. Why? We need to tell them that actually better things are coming. Research is going on. When I started the medications in 1998, because I tested in 1994 and started the medication in 98, I was taking 15 tablets every day. In the year 2000, I was switched to 7 tablets a day. The medications came, which had to be kept in a fridge, which I didn't have. So I had to improvise a local fridge in my house. Dug a hole, put there a pot, put there water, stones, and a piece of cloth where I placed my medication. Every day I could check on it. And in 2000, better things came. Right now, I'm taking 1 small tablet every day. 1 small tablet every day. And as I speak now, I've just been in America. I was invited by Griad, a company which has created an ARV which you take twice a year. You only have an injection in January and July. 2 injections in a year. It's called Lenapacavir. So we need to encourage people to know these things so that they can take their medications correctly, hoping for better things to come. What brings all these new things will bring the cure. So we don't discourage them from taking medications, the daily medications. We encourage them to take medications and tell them better things are coming. One of the things why I take my medications correctly, because I have hope that in 2 years or 3 years from now, I'll stop taking daily medication. Of course, I'll stop. What will prevent when research is going on? We need to have that optimism. Thank you so much for that comment.
Thank you, Supercharger. I'm not sure if there's a comment online, but you can see that our next speaker has already joined the Zoom. Yes, John, you can come. There's another question.
Yeah,
for
I'll
you.
give room for the next speaker if she's already there.
Yeah, there's another question for you.
Okay.
Good morning, Supercharger. My question, I don't know if it's a question, but it's like my brother's comment over there. It's that while we are looking for we are advocating for this initiative, can you also look at we know, we've seen it when we started the treatment, HIV treatment, that we had a lot of side effects, then we had a lot of death and other infections or sicknesses that came with them. So can we, as we are advocating for this initiative, can we also be ready to deal with the side effects that come with the cure, and maybe look at things like we know in TB we also have MDR or XDR, that after taking the medication maybe you get the virus again, then maybe it's difficult to get cured. Can we also be ready to deal with such? Thank you.
Thank you. I'm not sure if you want me to summarize that question or you got it.
Please summarize it for me.
Okay, he was saying that yes, as we advocate for the cure, but we also need to also get knowledge in terms of what will be the side effects that would come with the cure, as we have also seen the side effects that comes with the treatment, including the side effects that you will get, especially when you take MDR or XDR treatment. So it was more, I think the next speaker will address most of the questions when it comes to what he has just said. But that was...
That when you advocate for HIV cure, remember I said one of the things you need to do is to advocate for the cure to come to your country. But when it comes to your country, you must advocate for safety of study participants. Now, these trials, when they are starting, they start in phases. There's what we call first phase, second phase, and the third phase. The first phase, they will test that medication on very few people, like 3 people, just to know whether this medication is not dangerous to a person. Because it's a new medication, even the researcher doesn't know its impact, doesn't know its side effects, doesn't know its danger to the person. You can't give it to hundreds of people, no. So first phase basically looks at the safety. So when they are doing first phase, it's up to you as an advocate to ask, okay, you are doing research in my country. At what phase? Researcher will say, we are doing first phase. How many people are in first phase? 100. Oh, why 100? First phase, they are supposed to be very few people, because even you, the researcher, you don't know the danger of this medication. So after you have passed first phase, where there are 2 or 3 people, that's when you go to second phase and bring like 100 people. Because you have already passed the safety stage, now you are going to this stage which is called efficacy phase, whereby now you are testing the product. Can it cure? You first test safety. So it's really up to you to make sure all these guidelines are followed. That's why I said, look and see whether the person doing the research is following the good participatory practices, the ethical guidelines of a research. May God be
knowledgeable about cure. Lots of myths and misconceptions, right? Supercharger, but there was a good amount of knowledge. And we think that part of the reason for that is because that community has advocates like Supercharger in the room and has been speaking about these things for some time. And that's one person, right? One person who's going out into his community, who's regularly talking about things. If you go, he's got a YouTube channel, and if you listen, you'll see lots of dance and music and kind of translating HIV messages into a language and format that people can really understand. But when you see Supercharger and Philista in a second, one of the things I'm hoping is that out of these workshops is the start of a process where some of you will want to be the next Superchargers in terms of cure. So, Supercharger, thank you. Thank you for all your support, inspiration, all the passion, and we'll speak with you very soon.
Thank you. Thank you so much.
Me? Too much? Too little? Okay. Philista, good morning.
Morning. How are you?
Good, good. How are things in Kenya?
Kenya is very hot at the moment.
Here too, a bit rainy, but all good. So it's my pleasure to introduce you to Philista Adhiambo from Kenya. I met Philista for the first time actually last year in Durban for a workshop on cure, where she was one of the, I guess, community leads helping to organize and support community education around cure. So Philista has done a little bit of work in her communities around cure and around cure education. And what we wanted to do is, along with Supercharger's presentation, give you a second perspective on how community work looks, once you get started, once you've got a little bit of knowledge, and then you've got the opportunity to practice a little bit. So, Philista, thank you for joining us. Thank you for being here. We've got a great group here that I've just walked in, lots of questions being asked. But over to you to hear a little bit about your work, and then I'm sure we'll have a lot more questions for you later on. Thanks.
Thank you so much, and I'm really excited to share my experiences today with the group that is there. I've been introduced, and I would like to add on to that I am an HIV cure fellowship guarantee for the year 2019-2020. So I will with the International AIDS Society and EVAC. So I was able to make an application, and the application was successful to do some advocacy work around HIV cure. And I was basically looking at the barriers and HIV cure in Kisumu, Kenya, where I was able to engage different groups of people. I was able to engage young people. I was able to engage sex workers, religious leaders, healthcare providers at the local and national level, and even at the county level. And I was also able to engage the Muslim community that is always left behind. We've always had this assumption that the Muslim community is not so much affected with HIV. So I was also able to get their perspectives on what they think about HIV cure. If I may begin, I would like to say that we've come a long way with HIV since it came. And we've made a huge stride. We began with not knowing what the disease was initially, and our governments not accepting that we had a problem. But then the pandemic was there, and it had really eaten into our community, and so many of our communities were infected, and most people were dying. So later on, our governments accepted, and we began accepting that indeed HIV is a big problem to us. And since then, campaigns and advocacy work began, and we can clearly see that the advocacy that was done has yielded fruits. There was no medication there then, and you could be tested but still could not have hope. But then through advocacy, we were able to get this medication. So I always say that HIV cure, HIV prevention is the backbone of HIV cure. So we cannot have HIV cure in isolation. These things go together. Because in order for us to have a cure, the scientists have learned a lot from right at the time of testing up to now. So these things have to go together, and we'll still emphasize the need of prevention, treatment, care, and now we have to emphasize the importance of HIV cure. And some of the things that come to mind when we think about, do we really need an HIV cure, is first, the dwindling funding for ART is going down. So it means we have to do something. We've talked about the drug side effects. Some people are failing. So what happens if people fail these different lines? So that one means our researchers and scientists need to really work tirelessly to get an HIV cure. And we are proud to talk of certain strategies of HIV cure because we have the latency reversing agents that our scientists are trying out, and they seem to be working. We have the immune-based therapies. Those are the monoclonal and broadly neutralizing antibodies that are working also. We have the gene therapy that is also being tried in Uganda, and Supercharger is really privy to that. So we have hope that it is possible indeed to have an HIV cure at this time of age. And communities to ensure that HIV cure is well understood, is well consumed with our communities. Because if science is just done and kept in the laboratory somewhere and it is not consumed by people, there is no way we will get to know whether it really works. So the main issue here is, how do we get our communities to know that indeed an HIV cure is possible in the coming years? So first, HCAAP has now organized this meeting today for you to learn more about HIV cure, and you'll be the first ambassadors in your country to know more about HIV cure, what it is. So HIV cure, these are strategies that our scientists think could be able to control or completely remove the HIV virus from the body, if I can give you in a layman's language. So these strategies, once you've learned about these strategies, then you have some knowledge, you have at least a base of knowledge. So once you have this knowledge, ensure that you have the right knowledge, the correct information, and be able to internalize this information so that you may be able to disseminate it to another person. So first, you'll be the custodian of this knowledge, and this knowledge needs to be consumed. We cannot talk about HIV cure in these meetings without taking it to the people outside there who are consumers. So we need to build the capacity of our communities to know what HIV cure concept or this new idea about HIV cure is, and get their perspectives on what they think about HIV cure. Let's understand what are some of the cultural issues around HIV cure. What are some of the political issues around HIV cure? What are some of the economic issues around HIV cure? Will we bring a cure? Maybe that the community will say that we do not actually need an HIV cure because ART work for us. So those are some of the critical questions that we need to ask ourselves and really find a way of explaining properly the HIV cure agenda to our community so that they may be able to make an informed decision to participate in trials, clinical trials that are going to conduct research on HIV cure. Is our government going to say, looking at it politically, is our government going to sail with the same agenda of saying, no, we do not need a cure and we can only buy ART for our people? So these are some of the things that we need to understand in advance so that when the cure is here, when the cure studies are here with us, when we are being asked to ask our communities to participate in them, then there are no barriers to it. Instead, participate in them so that we can get evidence from the science that is being developed. We have to look at the issues of accessibility also. Whom is the HIV cure strategies going to be accessible to? Is it going to be accessible to everyone? Is it affordable? We have to look at affordability. Is it something that is going to be tried in our communities and thereafter will not be able to access it, will not be able to afford it because of high cost? So these are things that we need to really understand and begin talking about. Let's have debates concerning these with our community. Is it something that is going to be scalable to our communities? Or is it going to be a preserve of the few who have the money? So these are questions that we need to ask about HIV cure intervention. Because as we know, Africa, sub-Saharan Africa has been really been impacted with HIV. We have to also ensure that now that the education that we are giving people who are living with HIV in our communities is ART for life. So how are we going to transition these people into the cure agenda or into the cure strategies smoothly without any conflict of interest between the healthcare workers, the patient who is taking this ART, and not causing more problems to the patient? So we need to advocate for this and speak to them and really explain to even the healthcare providers. Not everyone has the knowledge on HIV cure. This is a new concept, a new idea that researchers have come up with. And if you listen to Supercharger, he's talking about most of these researches happening in the West and not in sub-Saharan Africa. And we need to really amplify our voice that these researches need to happen in our local setting, and the capacity of our medical practitioners needs to be developed so that they may have knowledge. As much as the lay people might talk about HIV cure, these our scientists also need to be to acquire capacity building in order to really understand what the concept of HIV cure is. We also have to strengthen stakeholder engagement in our communities on HIV cure. Now that you are an ambassador, an advocate, at the end of the day, you will have some knowledge about HIV cure. You don't need to begin big. You will begin with that little knowledge and disseminate to these stakeholders in our community so that they know that there is this new concept that is going on. We have examples, living examples of people who've been cured of HIV, such as Timothy Brown. We read over the news. So we can begin interrogating such, how did that cure begin? And is it something that is replicable in Africa? And also, in Africa, we've been talking about elite controllers. those people who've been able to control HIV without taking any medication, concept that is happening in Africa, or it is something that we've been just thinking about. We have the post-treatment controllers, and we've seen religious leaders praying for people and claiming that some of these people have been healed of HIV. Is it a case of a post-treatment controller? So we need our scientists to really get engaged in these things and ensure that also the knowledge that is outside there is the correct knowledge, so that religious leaders and medical practitioners can work together to demystify some of the myths surrounding a cure of HIV in sub-Saharan Africa. We also need to work with these different stakeholders, because the knowledge that they have some knowledge, and also the scientific world has got knowledge. How can we marry these two knowledge so that we do not conflict each one, but for the good of the community, so that the community can benefit from the HIV cure? We also have to begin talking about risk versus benefit. What are some of the risks of these HIV cure strategies, and what are the benefits? Who is really going to benefit from the HIV cure strategies that are being proposed? And what is the best HIV cure strategy for sub-Saharan Africa in case of the few that I mentioned at the beginning? So what will work best? We also have to ensure that there is a participation at all levels. We need pediatric participation. We need adolescents to participate. We need adults to participate in HIV cure. We need male and female to participate in HIV cure, so that we can really get sound evidence on whether HIV cure strategies work for our population, and whether in future it's going to be generalizable to our communities. We need also to begin engaging our countries and our Ministry of Health on policy guidelines also that are there. Because as it is in Kenya, the ART treatment guidelines will not allow for a concept known as analytical treatment interruption. So how are we going to ensure that our governments ensure that these policies also are changed to accommodate for analytical treatment interruption to happen in a research setup, and not also like affecting the patient who is seeking treatment at the patient support centers, in order to increase uptake of HIV intervention, or HIV cure interventions that are going to be available. We need also to engage. We've been complaining about shipping our samples to the West, shipping our samples to South Africa, to the biobank. So what are we putting in place? We have to begin talking, what kind of infrastructure do we require to be able to really conduct and perform HIV cure research in our setting at an affordable cost? And also we have to look at what are some of the cultural barriers, political barriers that are going to affect the smooth implementation of HIV cure in our settings as it is. So these are main things that we need to begin talking about. And looking at it also, we need to talk about equity. We must ensure that HIV cure, when it is available, we'll ensure that we have equitable distribution of these services to our people that we have. And ethics, we need to engage our ethics committees, institutional review committees, and we need to begin talking about issues of compensation also. How are these people who are going to participate in HIV cure research going to be compensated? How are they going to ensure that human good clinical practice is really maintained throughout the HIV cure research? And how are they going to monitor and evaluate these activities while they go on in country? We also have to look at issues of stigma, which has been a challenge in HIV treatment, stigma, discrimination, issues of non-disclosure. So how are we going to address this? Because each and every community is unique, and each and every community has to come up with ways on how we are going to mitigate this. Is it going to affect the implementation of HIV cure when we have the cure already with us? I hope everyone is warming up to the HIV cure the way I'm really passionate about HIV cure, because I know in order for us to end HIV by the end of 2030, a cure must be there to complement treatment. We need options for our community. And that is why I'm strongly advocating for HIV cure in our setting that has the big burden of HIV. And just to speak to the community, how can the community also help the researchers to really understand the expectation of the communities? Because the community also has got expectation. So how can we demystify issues of mistrust between scientists and the communities? These are areas that community should lead us and advise us on how best we can handle such issues, so that when the cure comes, then we have the cure, but there is no one who is willing to uptake on it. We also have to look at issues of who should be engaged during the HIV cure agenda. I will tell you, the HIV cure terminologies and languages can be a little bit complex, but they are learnable. There are things that you are going to learn today. There are things that you are going to learn. Maybe you thought a cure meant this, because a cure to our different communities mean different things. But you're going to learn a new thing today, or unlearn what you perceived to be a cure by the end of the day today. So how can our communities, and especially I challenge you advocates, how are you going to help us to really understand these complex, to simplify the complex terminologies so that our communities can understand? Through perhaps translating the language, through perhaps using videos to educate our communities, using songs, using poems to simplify the language so that our communities can really understand what we are talking about in order to be able to consume the product that we have regarding HIV cure interventions. And also, how do we get in? Because the cure, our scientists have been accused that the type that we have a cure in the West, because the type of ART that we have in the West is different. So how are we going to demystify such misinformation in our communities? We need to think around those areas. What are some of the myths and misconceptions around HIV cure? And how best are we going to address these issues as a community? I would like also to touch on communication, information, and educational materials. How are we going to work around these? Because this is critical and key to educating our communities on HIV cure. We need to think around these areas and really make sure that this information is well simplified, and look at it in this aspect. How are we going to ensure that our illiterate, because I've realized from experience working with communities that even illiteracy is stigmatized. So how are we going to ensure that our illiterate folks are able to participate in HIV cure comfortably without any intimidation in cure research? So these are some of the things that we need to look at and ensure that our people have this knowledge. We also have to negotiate for a comprehensive HIV cure package. So what is the package for an HIV cure? What is it going to be? For instance, whereby your treatment is going to be interrupted, what is going to happen thereafter? So we really need to understand what is an HIV cure package going to look like in order to educate our people about it. I will stop at that and maybe welcome now questions. Thank you.
So I know when you look at Philister and Moses's presentations, it can seem quite daunting, right? They're doing lots, but I think the point is that cure is not being talked about in many African countries, and so for it to get on agenda, there needs to be demand, and we can learn from the experiences of Uganda and Kenya, which may be a little bit further ahead in some ways, that this is not just about advocating for a new drug because there's a supply chain already there and you just put the new drug in and it goes. This is about potentially, you need infrastructure is what's being said, you need kind of people to train, you need research. We want trials here, as Supercharger and Philister have referred to. Most people living with HIV are here. So why would cure trials, when they do begin, why would they mostly happen in other parts of the world? So hopefully a lot to take in. Hopefully you have a few questions. So Philister, please come on up like you did earlier, and please come on and ask your question.
Thank you so much, Philister. Do you hear me?
Yes, please. Go ahead.
Okay, thank you. Thank you so much for the presentation you've made. So from your presentation, you've mentioned that you have engaged young people and female sex workers. So my question is about how maybe have you tried, or have you maybe think of maybe engaging other key population groups like transgender people and men who are having sex with other men? Because in country we have got data which shows us that there are a lot of key population groups who are living with HIV. I think maybe from this initiative could also allow us maybe to benefit from it. And also I've got another question. I don't know if Mr. Supercharger is online maybe to answer this another question of mine. Is he online? Oh, okay. Oh, okay, thank you. So maybe from the research which has been made so far about the HIV cure. So maybe when taking the HIV cure medication, will it be taken once off, or will be taken maybe for a particular time, and then maybe this person will be then tested again to see maybe the virus is still in the body? Thank you.
Thank you. Great questions. So on the second question, after the break, which is next, we will have a very special presentation from Dr. Tumbi Ndungu, who's based in Durban. and he will actually talk about exactly what your question is referring to. But feel free, Philista, or if you want to step in, Supercharger, when we get to the second question to have a go at that. But if you want to talk about engaging further key populations, Philista, in your program, I think that was the gist of that first question.
Okay. Well, okay, thank you so much for those questions. So I will say you are interested whether I was engaging a key population. So sex workers is one of the key population. I was able, during that time, I also came to learn that there were also male sex workers and the MSM community. So I could not really separate them. So being that my interest was more on sex workers, but still I was able to also engage these various groups and they gave their perspective on what they think they require as key population regarding HIV cure. And some of the things that came out clearly was on the issue of safety of participants. And another thing that comes out strongly when it comes to key population is the issue of discrimination, stigma-related issues, and also healthcare provider attitudes and how that could be addressed so that they are able, when an HIV cure intervention comes, then they are able to freely walk in because they felt like there is a lot of stigma and whenever they want to seek for any services. So these are things that when we are developing maybe cure models, we need to factor in and ensure that we consider the needs of key population, because this is a special population that needs a lot of consideration. And for the second one on whether the cure should be taken once or to Prof. Thumbi in the afternoon, because he's got more knowledge on that, and then he will tell you exactly what they think a cure will look like. Thank you.
The one thing I would add, okay, is that everybody we are working with, everybody who I know in this space is working for a cure for everybody, you know? So that means every key population, every individual, regardless of where they are in the world. And I will talk a little bit later because of the start and because I had to go run around. I wasn't able to do my introduction, but I will do that a little bit after this and this afternoon. But very, very importantly, if you work with key populations, cure is absolutely relevant for your populations, and the effort, Supercharger says this all the time, we're all human, right? And the cure is for everybody. So any other questions? Philista, please come on up.
Thank you, Philista. Maybe if we're speaking on monetary terms, I would say I have a balance that I'm bringing forward. Anyway, I think you're in a good space to answer me. Maybe first I would like to appreciate the presentation that you made to us. It's informative. It's informative, and we appreciate the new concept, the HIV cure concept. We appreciate the research and the developments that are made. But having said that, I'm not sure whether I'm incapacitated or I needed trauma counseling, because the first time I heard about HIV, the information I got while you speak of the issue of correct information, I got that HIV is incurable. Since it is a virus, viruses are not curable compared to bacteria. So maybe the research has developed into a time or a situation whereby things have changed, which I think that is where we have to start, maybe to change maybe the information. I understand the issue of the freezer versus the cure. That's where I'm lost to say. You said the first speaker spoke about the freezer, which will freeze the virus not to multiply and stuff. But then the cure part of it makes me somehow traumatized. And we usually go to hospitals to receive our treatments and maybe our refills and everything. We do our tests and it comes out, and we are not even sure what is written in those tests. They speak of CD4 count. Well, it was explained it's the white blood cells, but then there's also CD3 and other things that we do not understand what they mean to our lives. Maybe all those things need to be addressed as we move forward. Maybe I can stop there for now. Thank you.
So thank you so much for those great concerns that you've raised. Really, I think that is the knowledge that is all over the world, that HIV is incurable, because it is a virus. But with the evolution in science and development of new assays in the lab, so our researchers have been able to really study the HIV virus. And that is why we even have the ART. They've discovered that even the ART that we are taking actually suppresses the virus. It suppresses the virus, and that is why at some point when you are tested, the virus is undetectable. And some people, at that point, they will claim that they are already cured of HIV, which is not true, because HIV goes on to hide in some of the cells in our body, like the brain cells, they hide there, in our livers, in the hidden most parts of our body. So what has been challenging, as much as we've been able to treat HIV, but we still have these stresses of HIV that are hidden somewhere, that has been difficult to reach. So scientists have been thinking, if the ART is really working and taking, ensuring that the virus is well suppressed and people can even live for long. So how do we target this hidden HIV virus that is somewhere? So that is how the cure idea came in. How do we target? Because it is just hiding. And some of the things they were scientists think of, can they wake up that virus? Then it comes out. And then they use some agents to target it in order to completely kill it off. You see, using medication, using the monoclonal antibodies, broadly neutralizing antibodies, the gene therapy, the block and lock, you see, latency reversing agents. So those are the things that they are thinking. So, so science has really advanced, and that is why now today we are not talking of HIV being incurable, but we are bringing this agenda that it is really possible to cure HIV. And we have these agents that scientists have been trying, which have proven, like I will talk confidently of the monoclonal antibodies. This is something that really scientists are looking forward to, that in future it's going to enable us to really have HIV as a thing of the past. I totally agree with you when it comes to terminologies used in the HIV field, or in the, I can say in the medical field, or in the research field. The CD4, the CD3, white cells, we really need to educate our communities, because if I tell you, okay, how your CD4 is this number, your viral load is this and this, you see, if I do not explain how beneficial it is to you, or what it does to you, or what it means when it is this much, then it's not useful. So these are areas of maybe when it comes to education that is being provided to our participants in research and also patients at the clinic. So this is an area that really needs to be looked at also. Thank you.
Thanks, Felista. Yeah, 1 second. So on this issue of cure and incurable, just to be very clear, we do not have a cure right now, right? So for the general population, for anywhere in the world, it is incurable. The science suggests that a cure is possible. So let me ask a quick question before we go to the next question here of you. Has anybody ever been cured of HIV? I speak loudly. Say yes, no. You say yes? Yes? Not yet. So we've got both views. So we've got one person saying that yes, there has been cure. Do you know anything about this cure? Okay. Okay. So we're going to get into the science of cure after the break in a minute, right? But there have been like 5 cases of people who were cured of their HIV. Okay? But very importantly, this is very, very important, and Dr. Tumbi will tell you about this. They had cancer, and they had a bone marrow transplant, okay, which is a very complicated and actually quite dangerous procedure. And they received a bone marrow transplant from someone who had an immunity to HIV, a natural immunity. And so after the procedure, when they recovered, they had no more HIV. It was eradicated. So scientists are learning, for example, from those experiences. Okay? And Dr. Tumbi will talk to you more about that. So that's what we say. Generally, it's incurable. Please, if people are on treatment, we encourage them to be adherent and stay on their treatment. We do not have a cure that is widely available right now. But the science suggests that it is possible. Okay? Based on some of these other experiences and some of the other technologies that Felista referred to. Another question here?
Okay, thank you very much, Doctor. My name is Kevin. So I have a question for you. Maybe you will shed some light here. If we're learning from you the Uganda experience, what has been the challenges in when engaging government, the Ministry of Health, in advocating for the cure? What has been the challenges when you're engaging those guys? And the other thing is that moving forward or learning from test and start, the way the community has been engaged, I think we need to learn from that, because it has been a one study that has brought positive results. And then also coming back to our African arrogant governments, people who do not want to share information and not knowing, I don't know, but I think they do know, they're taking advantage of the masses that information is a human right. So if they do not disseminate such information, how then do they think the uptake of the medication, the uptake of whatever is being studied upon is going to reap positive results? And then also treatment and cure also, that is also a human rights issue. We have a problem in the country. We've got no drugs. We've got, in some facilities, nothing as Panado, no Panado in the hospital. So I think it's important also, while we are advocating for these things, to put the issues of human rights attached to it. Thank you.
Phyllis, do you want to have a go at those
Yes.
questions?
Yeah, so let me go. I'll begin with the first one, challenges engaging the Ministry of Health. So the great challenge that we have is most of the Ministry of Health staff are not even aware of HIV cure. No, they don't have that knowledge completely. So it is a new thing that you are introducing to them. So you really have to have your facts right and tell them exactly the right information that you have. It's good always to acknowledge that we do not have a cure, as Dom said. We do not yet have a cures. But I've said these are new ideas that scientists think could lead us to obtaining a cure. And what the first cures that we had, we can say like of Timothy Brown, that was an accidental cure because this person was being treated of cancer and also at the same time had HIV, you see. So it's only that through curiosity, the doctor now began monitoring this patient well, and that is why they are more advanced in the cure knowledge than ourselves. So another challenge is that the Ministry of Health officials or medical doctors will tell you often that the HIV virus is a wild virus that cannot really be cured, and they do not think that it's possible. You will get such sentiments, but when you get such sentiments, but if you have the right information, the right knowledge, like I was taken through the basic HIV knowledge, I was taken through the various what HIV cure means. Then I made a presentation to them on what an HIV cure is, the strategies that have been proposed, the people who've been cured of HIV controllers, the post-treatment controllers, and with that understanding, they were able to warm towards it. And at the end of my presentation, I was actually given approval to engage the Ministry of Health official and even the patient at the patient support center. And they agreed completely with me that it is necessary that we begin having cure research in Africa too, so that we can get also findings that resonate with Africa, so that we can provide examples that happened within our settings. And also you've talked about communities to be engaged. Yeah, communities need to be engaged. We don't engage communities when we get only positive results. Even negative results are important because they inform a process, they inform the development of a particular product. Just last week, we had the unfortunate news that the mosaic vaccine that was being tried was not really working. But it is good news to the scientific world because there is new knowledge, new information, new assays that have come out of it that is going to form the development of a vaccine in future. And we are still proud that we also still have other options that people can still use in the meanwhile as we pursue the development of a vaccine. I would like also to give an example of the antibody-mediated prevention study that took place in sub-Saharan Africa in several countries, whereby they were trying a monoclonal antibody. The results of this study was not really promising the way we thought, but there was one important lesson that we learned. We learned that broadly neutralizing antibodies can be used to prevent HIV. Though, we also learned that for us to really prevent the different strains of HIV that exist in different parts, we need to have a combination of the different antibodies combined together. So that was a huge finding, and scientists are pursuing that. So we need to share with communities positive results. We need to share with communities negative results and tell them that from these negative results, this is what we've learned, and this is what the scientific world is going to move ahead to study it further so that we may be able again to come back with this new idea. People who do not want to share information, that was not clear to me so much. And well, let me talk about treatment and cure. It is a human rights issue. So shortage of drugs is something that we've lived with, and I agree. We need to have the human rights, civil societies talk about it, engage our governments. Why are we having stockouts in our health facilities of ART? And yet we know this is what is keeping our people living with HIV. So we need to talk. We don't need to stop because we are talking about the HIV cure agenda. As I said, HIV cure, because there is the concept that scientists also think that if we have a smaller size of that hidden HIV virus, the HIV reservoir, then it will be even perhaps easier to cure HIV. So we need to not to relent at this particular moment. We need to stand up and voice the need of having medication for everyone who is living with HIV, because that is their human right to receive treatment that has proven to work. And even for those people who are also negative, we need also to advocate in our country for PrEP, because we have PrEP option. We have Truvada, we have now the long-acting cabotegravir, which is already available in South Africa, Uganda, and Zimbabwe. So other sub-Saharan African countries need to advocate for the availability of those products so that we prevent, we at the same time treat, and when the cure is going to be here, we also participate in cure research so that we ensure that if the cures are going to work for Africans, then we'll also embrace it when that time comes. Thank you.
Thank you, Philista. Thank you. I do want to let Philista go. We are about to go to break. Does anybody have a final quick question that they would like to ask? No? Okay. Philista, thank you so much for your time and for answering all the questions and for also talking about the experience in Kenya. Supercharger, if you could hear us, thank you as well for your experiences in Uganda and both of your continuing efforts to support communities in countries far from where you are, but recognizing that, you know, this work needs to happen broadly. So please give them both a big round of applause. Thank you. You're relieved. Thank you. We'll speak soon.
Bye.
So very quickly, I know many of you didn't see me when I first arrived, but so my name is Dominic, and I'm with the HIV Cure Africa Acceleration Partnership, and we're partnering with the network here to support this workshop today. I'll talk to you a little bit more about HCAAP after Tumbi's presentation and before the kind of the workshop session after lunch. But what I really wanted to say is it's great to see so much participation. It's great to see the comparison actually with yesterday's group, which was kind of a young person focus group, and lots of commonalities, but also some different topics coming up and different interests. We're now going to go for break. Please come back for 11:30. Dr. Tumbi Ndungu will be joining us from Durban. He's one of the leading scientists in the world on HIV cure research. He's worked very closely with us. He's really committed to supporting communities, even though he's a doctor, scientist, researcher. And I think you will love his presentation. He will go through many of the questions that came up in this last set of questions, many of the things around treatment, the strategies, what it actually means, and so all your questions, store them up and make sure you're ready to fire them off to him. Otherwise, enjoy your tea, coffee, and we'll see you in a few minutes. So slower and louder. Okay. So I will do my bit now. Talk to you a little bit about HCAAP and why we think it's important to engage communities. But as soon as Dr. Tumbi connects, we'll switch to him. Okay? So, as I mentioned, my name is Dominic, and I'm with the HIV Cure Africa Acceleration Partnership. And the reason why we're here talking about this is, you know, as the speakers have already alluded to, cure is some way off, right? We're talking about maybe 10 years' time, 15 years' time, and Dr. Ndungu is going to tell you about some of the strategies that we're taking to get there, and you will see why it's going to take that long. So you might be asking, why engage communities now, right? So first, I think we're talking about HIV, and community has always been at the heart of anything that happens in the HIV sector, including on the research side. So from an early stage, there were things like community advisory boards, community meetings, community reviews of things going on in the research space. Not always in places like Eswatini, but in other parts of the world. And so we think because that research is happening now, communities here should be engaged, right? And here, because most people living with HIV are in Africa. I think Supercharger always mentions that we need to be at the table, Africa needs to be at the table, because 21 plus million people out of the 35 million people living with HIV are on the continent, right? So that's why we're focused on Africa and on communities. Now, why now, right? So if you go back to another innovation from a decade ago, over a decade ago, PrEP. PrEP arrived in places like the United States in the late noughts, so 2008, 2009, okay? And it took 5 or 6 years before it became widely available in places like this. But even today, most countries have very low take-up of PrEP, okay? And so why? Why was that? Well, because when we think that a large part of that has to do with, yes, there wasn't, you know, a government push, and yes, the access schemes weren't there to make it available sooner, but a lot of it has to do with once the product was available, there was a little bit of confusion or lack of knowledge that it even existed or what it was or how to, you know, how would it fit as a prevention at that when it first came out, innovation. And so you ended up with a product which is highly effective at preventing HIV when used appropriately, sitting on the shelf, not being used, even to this day. We don't want that to happen with cure. Imagine in 10 years' time we have a product that actually is highly efficacious, is safe, and offers the possibility of a cure. But if people don't understand, have not been brought on the journey a little bit, if something just magically appears, at least in what they think just magically appears, there might be a little bit of mistrust. But if people can see that the journey and that it's a bumpy journey and they've been consulted along that way, then maybe there'll be a little bit more acceptance. Because if we do get a product, if people like Dr. Ndungu, who will speak to you soon, are successful in their efforts, I don't think it's going to be a simple conversation to have. We talked earlier about HIV being incurable, and we talk about people living with HIV being adherent. Take your drugs every day, right? That's what we've said, and we've said that for decades now. And all of a sudden we're going to say, well, we've got this option, but you have to come off your drugs. You know, some people will say, no, I'm happy. I take one pill once a day. I don't have any problems with it. For other people, they'll jump at it in very quickly. But there'll be a lot of people in the middle who might want to think of this as an option. And we'll have to figure out how do we do cure counseling, I guess, in terms of helping people, support people to make that decision for themselves. So this is one of the reasons why we're engaging communities now. So that education, that there is a body of people in a number of countries who are thinking about cure, who might be doing a little bit of cure activity. We're not asking anybody to go out and start doing cure activities in their communities tomorrow. What we are suggesting is maybe after a workshop like this, is you want to think about whether cure has a place in your literacy efforts at a community level, and how do we incorporate that? Maybe you also want to say, well, actually, we think Eswatini should be at the table now in these discussions. And how are we going to do that? And you want to go to government and talk about developing a strategy. And it may not be end-to-end working on cure, but it may be, you know, Dr. Tumbi will talk to you about a trial that, for example, he's doing in Durban. Maybe it's just about having a trial or trials here for cure when they become available. So it's one about literacy, it's around having a plan for the country, maybe, if that's what you guys choose. And the third element, I think, is I don't expect everybody to come out of this workshop and say, cure enthusiast, we're going to go and we're going to devote our life to it. But maybe a few of you think, actually, this is something that I'm really interested in and I really want to get involved in. And there are lots of like webinars and other things that happen that we will start to kind of share the details of, and so hopefully that will be an opportunity for you to get involved. But there are also things like Phyllis mentioned the Cure Academy, the Cure Fellowship, which she was on, right? This is a program, runs every year, it's competitive, you have to apply, but maybe some of you in future years will be applying to do that because that's something that you think is the way you want to go forward. And what we hope is that some of you might be interested in being connected into some of these global cure efforts, and that you can bring a local perspective from here into those discussions about what's needed, when, how we deliver it, everything else. So that when we put up a picture of all the people who are involved in cure, if you looked at it 5 years ago, it was mostly white. Now we've got far more people from the continent involved, but hopefully in the future there'll be even more so, right? So there's no promise that it will happen. You know, we can't be sure, we cannot guarantee a cure product will be available by X date. But the science, as you see, is promising. And regardless, we think communities should be at the table having these discussions, informing you know, the work. So that's why we're here. So before I go on further, let me just see if we've had any connections. No? Okay. So, okay, yeah. So he says he should be here within 5 minutes. So I can do my second bit. So one of the reasons why we get you here today, the morning, is about us sharing information. So we've connected you with 2 advocates in Kenya and Uganda, Supercharger and Philister. You're going to meet Dr. Ndungu and talk a little bit about the science. Don't worry if all of it doesn't make sense by the end of it. We realize that it's new, you know. But the second part of the day is really, really important and a critical part of this workshop. Because the second part of the day is we want to hear back from you about your thoughts. What are your outstanding questions? What are your hopes based on what you've heard this morning? What are your worries and concerns? And then we'll ask you to look at a community level, at an individual level, what you think we should be doing in advance of a product being available. And the reason why we're doing that is HCAAP originally, this piece of work, was supposed to be around something that people use a very fancy terminology, human-centered design. They said the cure product should be, you know, focused on people. We should use human-centered design to develop it. So we started these workshops thinking about, okay, we're going to engage communities and get them to feed into cure product development. But what we realized was this is not just about a product, injectable pill or whatever it is. It's about education, it's about policy, it's about access strategies, it's about literacy, it's about counseling, tackling stigma discrimination. It's not as simple as just a pill. So we said, well, why don't we start, instead of just saying this is what we think is needed, why don't we start speaking to communities, giving them a little bit of an introduction into Cure, and then going back and saying, okay, what do you think we should be working on moving forward? What do you think are the priorities? And the way that we've suggested we do that is by focusing on what you are most hopeful for and what you're concerned about. Because that varies from country to country. In Zambia, about 20 years ago, there was a minister who worked on HIV. And he had a company that developed a kind of a herbal remedy, which he marketed as a kind of a treatment / cure for HIV. One second, let me just do this. I had a cold last week, which is anyway, this formula, Sondash, which has been around for 20 years, has never been through a clinical trial, never been proven, but a lot of people want an African product. A lot of people, traditional healers, they want to use a herbal remedy. And so this has a lot of popularity in Zambia, right? And so we've been saying, we ran some workshops last year in Zambia with the National Network and another organization. We had the minister, the head of infectious diseases there, who was talking about this. Their plan in terms of how they're going to move forward will include sensitization, will include work with the ministry about looking at a plan and what research might they be able to get to Zambia. But as I said, every country is different. Their plan has to also specifically address the attitudes towards this product that people are familiar with, and some people talk about as curative or a treatment. I'm not saying it doesn't have any impact. I'm just saying it's not proven. It's not been through a trial. It's not been through anything that we would normally require before we make something broadly available. But that's specific to Zambia. What we're hoping to find out today and from the workshop yesterday is what would we need to do, or what would you need to do? We don't do anything. We're far away. We want to support you to do this. But what would need to happen if you think Cure should be on the agenda of the government here? Okay, so that's what we're going to do this afternoon. So we'll have Tumbi's presentation, plenty of time for Q&A, discussion, so hopefully get your head around the science. You'll be tired then, so we'll go have some food, and then we'll come back and hear from you. So, so let's restart that. There's always something new technologically, isn't there? Which browser do you use? Chrome. Is it Chrome?
It's a meeting that is.
Yeah, I know, but I use the login via browser. Yeah, but we use the meeting ID, which is in the before we use the URL, which browser is yours? Hi, Tumbi. Can you hear us?
Hi.
Ah, wonderful. Great. Sorry, just as you joined, it kicked us off and froze the computer, but everything's working now. So, I don't want to delay much further because we've cut into Tumbi's time a little bit, but please, it is a great honor and privilege to introduce Dr. Tumbi Ndungu, who's based in Durban and leads the Africa Health Research Institute, and we worked with another one of his organizations called Sante to run a similar workshop in Durban last November. So Dr. Tumbi is a leading global researcher working on cure, and he's going to talk to you about HIV science, but really around cure strategies, and talk a little bit about his work with a trial that is being conducted at the Institute in Durban. So with that, Dr. Ndungu, I'm going to hand over to you. Thank you so much for joining us today. We've got a great group, lots of questions and discussion so far. So I'm sure there'll be plenty more to come after you present. Over to you.
Thank you very much, Dom, and apologies that I'm joining late. I had another meeting and I got a bit delayed. My name is Tumbi Ndungu. I'm from the Africa Health Research Institute. I'm going to be talking. Can you hear me?
We can hear you.
Okay, and I think you'll have to help me move the slides. For some reason, I can't see the whole slide, Dom. If you can make it a full screen. If you click maybe on the right hand side there on top, no, up further up next to the X, yeah. Yeah, that one, yeah. Not next to the free. Yeah, maximize, yes. Okay, all right. I think we can just go on. So what I wanted to say first of all is that there has been tremendous progress in the way we treat HIV over the past 3 decades. This is figures showing how HIV was treated, for example, in 1996, when one had to take more than 30 pills, antiretroviral therapy pills, in order to treat HIV infection. And you can contrast that to the current situation today, where most people living with HIV need to take only 1 pill a day. And of course, the Food and Drug Administration in the US has also approved now an injectable antiretroviral that can be given once every 2 months. So there's a lot of change, and there is a tremendous progress in the treatment and prevention of HIV. And I think we need to celebrate this advances. However, despite this progress, there are quite a number of other challenges. And I'm going to briefly talk about these challenges and then talk about what are the most promising strategies for HIV cure. And then I'll use a fresh cohort, which is a study that we are doing here in South Africa, as an example of how to do HIV cure research, particularly in Africa. Next slide, please. So one of the challenges that we have is that, at the moment, antiretroviral therapies have to be taken daily. And you can see these pictures from Kenya. This I took from the Daily Nation, where they ran a story about how some children are having difficulties in taking antiretroviral therapy every single day. And these are children who are born with HIV, and they don't understand necessarily why they have to take antiretroviral therapy, while the rest of their peers are not taking these drugs daily. So there is a lot of fatigue associated with taking antiretroviral therapy, even though antiretroviral therapy are obviously very useful for the people who are living with HIV. So we need to find alternatives to daily medication, whether we can even cure HIV, so that we can make progress in the management of this disease. Next slide shows why, although antiretroviral therapies are very, very successful in suppressing viremia in people who are living with HIV, they suppress viremia to undetectable. The problem is that as soon as you interrupt antiretroviral treatment, the virus comes back, and this happens usually within 2 to 3 weeks. So as soon as somebody has interrupted treatment, the virus rebounds, and it doesn't matter how long you have taken antiretroviral therapy. Even if you have taken antiretroviral therapy for 10 years or 20 years, if you interrupt treatment, the virus tends to come back within a very short period of time. The reason for this is because of what you call HIV latency. And by latency, we mean that there are cells within the body that contain HIV DNA. They have the genetic information that is needed to make viruses, even though they are not producing viruses when somebody is on antiretroviral treatment. And this is because these cells are very long-lived. They can live in the body for more than for decades. As soon as antiretroviral treatment is interrupted, these cells will be activated and they'll start producing new viruses. So this is a big challenge for the eradication of HIV. Next slide. So essentially, when somebody is living with HIV, this is what happens in the body. You have two forms of infected cells. You have what we call productively infected cells. These are cells that are actively producing the virus. And these cells will be DNA positive, will test positive for DNA, HIV DNA if you test them. They will also be HIV RNA positive, and they will also have HIV proteins because they are producing viruses. And usually what happens is that these cells, eventually they die. In contrast, you also have what we call latent infection in the body. And these are cells that are not actively producing the virus, but actually have HIV DNA in them. So they're HIV DNA positive, but they don't have HIV RNA, and they don't have HIV protein. And these cells are, as I mentioned, are very long-lived. They can live in the body for decades. And as soon as antiretroviral treatment is interrupted, these cells will become productively infected. They'll start producing viruses, and some of them will die, but some of them will also infect other cells. So this problem of HIV latency is the reason why antiretroviral therapy does not cure HIV. Next slide, please. So the problem that we have, though, is that even though we know that there are these latently infected cells in people who are living with HIV, these cells tend to be very, very rare. It's about 1 in a million CD4 cells within the body, in the blood. So they're very rare. There is no phenotypic marker that can easily identify these cells. So you can't completely eliminate them because you don't know how to identify them. But we know that mostly these cells tend to be CD4 T cells. That's what we know. But identifying them and very, very difficult because there's no phenotypic marker that can identify them. Next slide. So why do we think that HIV can be cured, or what is the hope that HIV can be cured? One thing is that we know there are people who are called HIV controllers. These are individuals who are infected with HIV, they're living with HIV, but they are able to naturally control the virus. In other words, their viral load is below the level of detection, or even if it is detectable, it is at very, very low levels. And these are individuals who are not taking antiretroviral therapy. So these are people who are not on antiretroviral therapy. Their CD4 counts are normal and their viral load is undetectable. These individuals are called elite controllers or HIV controllers. And we don't fully understand the mechanisms of HIV control in these individuals. However, research that has been done so far suggests that these individuals have very good CD8 T cells, which is as an immune cell in the body that is involved in fighting viral infections. So these individuals tend to have very good CD8 T cells, even though there may be also other mechanisms of HIV control involved. So this tells us that it is possible to induce certain immune mechanisms, natural mechanisms of virus control in some individuals, although we don't fully understand how to do that using therapeutic interventions. Next slide, please. The next group of very interesting individuals are people we call post-treatment controllers. These are people who have taken antiretroviral therapy, usually within a few weeks of getting infected. So these are people who start antiretroviral therapy very, very early. And what scientists have shown is that a small percentage of people who start antiretroviral therapy during acute HIV infection, once they interrupt treatment, they go into what we call HIV remission. In other words, the virus does not immediately rebound, and some of these individuals can stay for years without the virus rebounding. In other words, they have gone into remission. So remission is possible, but it is not very frequent. Remission does not result in HIV cure because most of the times, even after many years, the virus still rebounds. We don't know who will become a post-treatment controller. So you can't ask people to interrupt or to stop their antiretroviral treatment because, first of all, the number of people who go into remission after they interrupt treatment is very small. And also we don't have a way to predict who will go into remission, and neither do we understand the mechanisms. We don't understand why some people go into remission after they stop antiretroviral treatment. So these are very important questions that scientists are currently addressing. Next slide. So we also know that the HIV cure is possible. It's very rare, but it is possible. And there are some examples of individuals who have been cured of HIV. For example, Timothy Brown was cured of HIV in 2009. He is someone who was living with HIV. He was on antiretroviral therapy. He developed a cancer that required him to get a bone marrow transplant. And he got a bone marrow transplant from somebody who does not have the receptors that allow HIV to enter cells. That receptor is called CCR5. So some people don't have CCR5 on their cell surface, and therefore they are resistant to HIV infection. Very rare. So he got a bone marrow transplant from somebody who did not have CCR5, and the virus did not rebound. Another example is this gentleman, Adam Castillo, also known as the London patient. He also underwent a bone marrow transplant, and also the virus did not rebound and has not rebounded so far. This also happened in a woman in New York who was reported who also have undergone a transplant, and she is also in remission, and they cannot detect the virus in any part of her body, so they think that she's cured, although she's still obviously being followed up to see whether the virus will rebound. Next slide is that, as I've also mentioned to you that post-treatment control is possible. So there are many cases now that have been identified of people who started treatment early, and then they stopped treatment and they went into remission. So all these cases tell us basically that a cure of HIV or at least remission is possible. The problem is that we don't know how to do this on a large scale for most of the people who are living with HIV. So what can we actually do about this? So next slide. The next slide basically just defines what we mean by HIV cure so that we are all on the same page. The first form of cure, when scientists talk about a cure, is where you have complete eradication of the virus so that the virus is no longer detectable. And that's what we call a classic cure. However, we can also have what we call remission. In remission, the virus is still there. It can be detected, but it is at very low levels, and therefore it is not causing harm to the individual who is living with HIV. And that virus cannot be transmitted to somebody else because the levels are so low in the body that the virus cannot be transmitted. So that's what we call remission. Now, what actually, how do we actually achieve either a complete cure, eradication, or remission? So next slide shows the two strategies that we are trying to achieve. One is eradication. I told you that the problem we have is the problem of latently infected cells, which circulate in the body, even when somebody is on antiretroviral therapy. So in order for us to completely eradicate HIV or cure HIV, what you need to do is get rid of these latently infected cells completely. And we will discuss in the next few slides some strategies for doing that. But the other option is to not completely eradicate the virus, but rather to induce remission. And by remission, we mean that we progressively reduce the number of latently infected cells. Usually, this can be done through the immune system. And there are many arms of the immune system, like cytotoxic T cells, natural killer cells, antibodies. All of these are natural immune mechanisms that our bodies produce. And these natural immune mechanisms can be used to progressively reduce the size of the reservoir. The reservoir, when you talk about the reservoir are the latently infected cells. So we can progressively reduce the reservoir so that we result in a remission where the person is not taking antiretroviral therapy, but still has HIV, but the levels of HIV in the body are very, very low. So when you talk about HIV cure, those are the two main strategies. Either we completely eradicate HIV from the body, or we are able to induce a remission where the person is able to control the virus using their own immune system, but the virus is present at very low levels and the person is not taking antiretroviral medication. Next slide, please. So there are many ways of achieving a cure that have been proposed. On the left-hand side of this figure, in blue are strategies for targeting the virus. So you can, for example, give very early antiretroviral treatment during acute HIV infection. And if you follow that up with what you call latency reversal, in other words, latency reversal simply means you wake up the sleeping cells that contain HIV. So those cells that are present in the body, the very rare cells that have HIV, that are sleeping, you wake them up with a latency reversal drug, and they start producing the virus. And when they start producing the virus, those cells will die. So that's what we call, that is what latency reversal is all about. The other way is to give pro-apoptotic drugs that cause the cells that contain HIV to just die. Immunotoxins can also be given, and you can also do what we call latency silencing. In other words, you completely block the cells that contain HIV from ever being able to produce the virus and replicate. So all those strategies shown on the left-hand side in blue are trying to target the virus itself. On the right-hand side, in power, attempting to stimulate the immune system so that the immune system itself can fight off infection. And some of these strategies include, for example, broadly neutralizing antibodies, T-cell vaccines, so vaccines that can make the immune system to be better, immunomodulatory agents that target various immune mechanisms within the body. There are T-cells, CAR T-cells, as well as you can perform some gene editing to try and enhance the immune system. So these are all the strategies that are being attempted for HIV cure. And in some cases, these strategies are not used alone. In other words, they are used in combination. So for example, very early treatment is a good strategy, but by itself, it will not cure HIV. And therefore, what people are trying to do is to say, can you give very early antiretroviral treatment and combine that with latency reversal and broadly neutralizing antibodies, for example? Will that result in HIV cure or remission? And that's what people are trying to do. So a combination of these strategies might actually work in fighting off HIV. Next slide, please. So this is how combination approaches work. So for example, you have these latently infected cells in people who are living with HIV. You can stimulate these cells so that they start producing HIV, so they become productively infected and they start producing a virus. And what happens when you start, when they start producing the virus is that they will be recognized by the immune system, and the immune system will then kill these productively infected cells. So you can see that there is a combination approach here, because first you're giving a latency reversal agent that makes these latently infected cells to wake up and start producing the virus. And then you're giving some immune enhancing drug that allows the immune system to recognize these latently infected cells so that the immune cells can then kill these productively infected cells. So a combination of these approaches, such as latency reversal or so-called shock and kill, and it's called shock and kill because first of all, you're giving some shock to the latently infected cells, and then you're killing the cells that start producing the virus. The cells that are latently infected will then be killed. So that's latency reversal, or sometimes you'll hear people use the term shock and kill. Next slide, please. Another strategy is to do a combination approach. As I mentioned, you can introduce antiretroviral therapy very, very early, soon after infection. And now, the problem we have with this strategy is that in most cases, you don't know when people get HIV infected. Most people come to the clinic when they are already in advanced stage of disease. But in some cases, in a few cases, for example, in a study that we are doing here in Durban, South Africa, we are able to identify individuals with acute HIV infection. And once we detect acute HIV infection, we put them on antiretroviral medication, right? Because it preserves the immune system. So it doesn't wait for the virus to actually destroy the immune system. And then you can intervene with various combination interventions, such as broadly neutralizing antibodies, vaccines, gene therapies, latency reversal agents, and then you interrupt treatment. And if you interrupt treatment, the hope is that some of these individuals may actually go into remission, because in most cases, in 100, well, let's say in almost 80% of cases, what actually happens is that the virus rebounds very quickly within 2 to 3 weeks. But actually what we don't know is whether some of these strategies will work so that some people go into remission. So we are doing some studies here in Durban, in the fresh cohort, for example, where we put people on treatment very early, and then we will be intervening, or we are already intervening actually with broadly neutralizing antibodies and an immunomodulatory agent, and then we are interrupting treatment to see whether some of these people become cured. And I'm going to talk about that a little bit more when I talk about the fresh cohort in my last few slides. Next slide, please. Another approach is to do what we call gene therapy. So in gene therapy, what you do is you try and identify the cells that have HIV in them, and you manipulate those cells genetically so that you can remove the DNA sequences that belong to HIV. Because if you remove HIV from the body, then you have essentially cured the person. And then you can also enhance HIV-specific immune responses to attack the cells that are HIV infected. You can engineer cells to be resistant to HIV, or you can target the virus itself directly. However, gene therapy, although it has a lot of promise, is also very controversial at the moment, and it's also very expensive. It's expensive because, first of all, it has at the moment it is being done ex vivo. In other words, you have to remove the cells from the person, manipulate them outside the body, and then infuse them back in. And that's very, very expensive. Can also be dangerous to do. And most resource-limited settings will not have that capability. In future, we may have what we call in vivo gene therapy, where you just need to give a shot to the person, and then all the magic will happen inside the body. That's for the future, and that's what we're hoping that will be possible in the future. At the moment, gene therapy is mostly ex vivo, where you have to remove the cells from the body, and that's a very expensive process and also not very safe. Next slide. So this is, again, gene therapy. What you do on the left-hand side is I was calling ex vivo gene therapy, where you take cells from the person who is infected or living with HIV. You manipulate the cells outside the body, and then you return those cells, you infuse them back into the patient. Now, this patient has to come to the clinic, has to be observed, sterile procedures have to be followed. So this is not a very easy process, and it's very expensive. So in future, scientists are trying to figure out whether you can do what we call in vivo gene therapy, where you just give one shot, maybe with a drug that is attached to a nanoparticle, so that it can penetrate into the HIV-infected cells. And then once inside the cell, the drug will be able to manipulate the cells inside the body when they're still inside the body and eliminate HIV. So this is what scientists are attempting to do in the future, but at the moment, in vivo gene therapy, as I mentioned, is not available. Next slide. So I just wanted to mention that it is very important for the community to be involved in HIV cure research. And I know that most of you in the room are community members, and I hope that you will agree with me that we need to advocate for this kind of research to be done in Africa, because there's no need to really do this kind of research in resource-rich countries, because the strategies that might be developed in those countries might not suit our resource-limited settings. So we need to do HIV cure research so that we can test approaches that can work in our settings. We can also develop the infrastructure. I told you that the equipment is expensive. So we need to develop the infrastructure, and we need the communities, our communities, to accept this kind of research. So it's very important there is also community engagement so that people understand what is being done. They can have an input into what is being done. They can say, this is acceptable, this is not acceptable. Only then are we going to be able to develop a cure that is relevant and that can be applied to resource-limited settings. Next slide, please. So finally, I have a few more slides where I want to talk about the FRESH cohort. The FRESH cohort is a study that we are doing in South Africa to try and see whether we can cure women of HIV. So what we do is we recruit women during acute HIV infection. And I don't have the time to explain how we recruit women who have acute HIV infection, but essentially we test women who are HIV negative twice a week. And because these are women who are in the communities, some of them are sexually active. So some of them, unfortunately, despite all our prevention strategies, some of them do acquire HIV infection. So those that acquire HIV infection, we offer them antiretroviral therapy immediately. And what we have noticed is that when you offer antiretroviral treatment immediately, you immediately lower the viral load. So this is shown on the graph on the right-hand side, where the peak viral load for those women who started treatment early is much lower compared to the peak viral load in the women who are not treated during acute HIV infection. And it's not just the viral load, you also preserve the CD4 counts. So the graph on the right-hand side, lower half, shows CD4 counts, and it shows that the CD4 counts are higher in the women who start treatment immediately. And the CD4 counts are important because they're an indicator that the immune system is good in those individuals. So the people who start treatment early have a better immune system, and their viral load is much lower. We are planning to do in this cohort, next slide, is to do an intervention. So I told you that we start treatment during acute HIV infection, which has a lot of benefits because it preserves the immune system, and also it lowers the virus. And so what we are also trying to do now is to see whether we can intervene in these women who have been taking antiretroviral therapy for more than 1 year and who started treatment during acute HIV infection, whether if we give them broadly neutralizing antibodies, a combination of broadly neutralizing antibodies. Antibodies are very effective in suppressing virus replication, but we're also giving them a latency reversal agent to wake up the cells that harbor HIV that are sleeping in the body, and then we give them the broadly neutralizing antibodies. And then we are interrupting treatment. And the question that we are trying to ask is whether this intervention of early treatment combined with broadly neutralizing antibodies and a latency reversal agent will result in either remission or a cure of HIV. So these are the questions that we are currently asking. We don't have the results yet. This is an ongoing study, and we don't know whether it will work. But we think that this kind of research is very important, particularly here in sub-Saharan Africa, so that we can find pathways to eventually cure HIV. Next slide, please. So this is my last slide, I think, and it just shows that at the moment, daily treatment is what we do to treat HIV infection. In future, we will probably have long-acting antiretroviral therapy and broadly neutralizing antibodies. But our hope is that in future, we can induce remission with combination antiretroviral therapies, or even a complete cure with ex vivo gene therapy or even in vivo gene therapy. We don't know when this will happen, obviously, and these studies need to be done in very well-controlled environments, but the hope is that in future, this will be possible to cure HIV. It's very important that this kind of research, again, be done in Africa, where the need is greatest. And I hope that through your involvement in this workshop, you can be advocates for this kind of work in sub-Saharan Africa, so that we can be able to cure this disease. Next slide. Yeah, I think that's it. Thank you very much.
Thank you, Tumbi. So I'm hoping, are you able to stay on for a few minutes for some questions?
Yes.
Okay, great. So you've just had a whirlwind tour introduction to cure science. You've learnt about the two major strategies. What are the two major strategies? One is where you remove it completely, eradication. And what's the other one? Remission. Okay, good. Any questions? Come up. Come so that he can hear.
I wanted to ask about the
remission.
Yes, in terms of reinfection, is there any possibility of getting reinfected again? Yes.
So did you pick that up, Tumbi? The question was about remission, and if you were in remission, would it be possible to be reinfected? I'd add, I think it would also be good to hear about eradication, and reinfection as well. But what is the thinking behind reinfection with either strategy?
So most of these cure strategies assume that there will be no reinfection. So the idea is that if somebody is cured of HIV, there will be no reinfection, or that if somebody even goes into remission, that there will be no reinfection. Obviously, we don't know that for sure, because at the moment, as I said, there is no foolproof way to induce HIV cure or even to induce remission. But the strategies that are being pursued by scientists assume that somebody who is cured of HIV or goes into remission will not be reinfected. Now, we need to do the research to actually find out whether people who go into remission can be reinfected or not. But the assumption at the moment, the working assumption, is that people will not get reinfected.
Great. Thank you. Next question. Do you want to follow up?
I wanted to ask in terms of drug resistance, because some of people living with HIV, they are on treatment. Have you considered in terms of drug resistance, are we going to have the same treatment when it comes to HIV cure?
Did you get that, Tumbi?
No, I'm afraid you have to repeat it for me, please.
Yeah, so it was basically about for people who have been on treatment and have resistance to certain classes of drug. Will cure work for them? Will, is that big part of the thinking in terms of cure design?
Okay. Again, the hope is that in future, anybody can benefit from a cure intervention. However, remember that at the current moment, most of this is research. So nobody at the moment, is able to say with any kind of degree of certainty that you can cure people. So what scientists are doing is just research and clinical trials to see whether this can be achieved. So in most clinical trials, they target people who don't have any kind of drug resistance. So the research is mostly being done in people who don't have drug resistance. And the reason for that is because it is assumed that it will be more difficult for people who have drug resistance to benefit from these kinds of interventions. Obviously, if these interventions work and they are shown to be effective, they could be extended to people who have drug resistance. But at the moment, all this research is mostly being done in people who don't have drug resistance.
Thank you very much, Doctor. Mine is a question of, this is a very good initiative in as far as I'm concerned. And would you agree with me if I said this, the time to start engaging our governments to start thinking about HIV cure and research in our different countries? Would you agree with me that it is now? That is my first question. The other question is, when training the HIV cure advocates, is there a training, a specific training that can be given to the people that are going to be advocating at community level for the uptake of the HIV cure when it is made available? Because I see this as a motivation to adherence for most of people living with HIV at community, because as you said earlier, the doctor before you said that adherence is the most challenging issue when it comes to treatment access. Thank you.
I think I got the first question about whether it's the time. Yeah. And I would agree that this is the time to start engaging governments and advocating. However, because there is no cure at the moment, I think what advocates can do and the community can do is to keep asking the government to engage in this kind of research, to start asking what are the programs that the government has to try and achieve HIV cure. Are there research programs that they are supporting? Are there, resources that the government is setting aside to try and explore the issue of HIV cure? I think that's very important, because at the moment we don't have a cure, but at least the governments can support this kind of research. The governments can bring in experts who do this kind of research, and you can advocate within the government, but also within the people in the medical profession and other areas like that, that there should be a program on HIV cure research. I think that's really important. But having said that, I do want to emphasize that there is no cure, and therefore this kind of research needs to be done in very well controlled settings, and people need to adhere to antiretroviral medication 100% unless they are in a study that is being very closely monitored, so that we don't cause any harm to anybody. I'm not sure I got the second question.
The second question to me was around training available for advocates around cure.
Yeah, so I think, there are many organizations that are involved in training. Obviously, this kind of training that DOM and the HCAAP team have organized is very important to raise awareness about this. But there are also other training opportunities. For example, the International AIDS Society organizes a research academy for advocates so that they are knowledgeable about HIV cure research and what is going on. And hopefully there will be much more initiatives of this nature to try and education and provide information. And maybe it's a good time for me to say this is an area that we ourselves as researchers would like to, African investigators would like to get involved in. And we just actually got a grant yesterday to help in this effort. And so we will be working with DOM and others to try and see whether we can organize more of these kinds of workshops or even longer ones so that people have more extended workshops, so that people have more knowledge about the issues around the HIV cure and to create awareness. But there is already, efforts like this, as I mentioned, by HCAAP, by International AIDS Society, and other groups like that.
Exactly. Thank you, and congratulations. That's great to hear about the grant. And one of the things that I said yesterday, and I hope that you will take away, is today is like the beginning of the beginning, right? This is a journey. Nothing's going to happen overnight on the science side, but even the change that we're talking about. But we're starting a conversation, and then it's up to you guys as a community to say, this is what we want to do, and then we'll have a discussion about how we might be able to support you to do that, So, any other questions for Dr. Tumbi before he goes? Come.
Thank you so much, Doctor. I think mine, it goes to those individuals which we find out that they've been cured of HIV from those which received those bone marrow. So my question is that were there any follow-ups, maybe tests done on them to follow up maybe the virus has reversed or something? Because what we know that yes, HIV cannot be cured right. So even if someone can test today and that person can test negative, but that person has to come back maybe after 3 months, to see if the virus is not in the body, So my question is based on that from those people whom you've discovered that HIV has been cured, were there any follow-ups, tests done on them that indeed these people have been or cured? The virus is not in their bodies. Thank you.
Did you catch that?
Can you repeat it, please, for me?
Happily. So the question was relating to people like Timothy Ray Brown and Adam Casiejo, people who have been cured of HIV, and whether there was follow-up of those people after they were cured to ensure that there wasn't a rebound or the virus didn't come back. Would you be able to tell a little more detail about how that follow-up, or what follow-up has occurred?
Yes. So in the case of Timothy Brown, for example, he was cured of HIV. The procedure was done in 2009. And Timothy Brown was followed for more than a decade, because I think he passed on from cancer 2 years ago or thereabout.
Yeah.
So he was followed very closely. They did every test possible to see whether they could his body, including he donated even some of his body organs, biopsies. So they tested and they couldn't detect any HIV in his body. So they concluded that he was cured of HIV. The same thing is happening with Adam. His case was more recent, 2018, 2018, I think, is when he underwent the operation. And they are following him. They have followed him now for almost 5 years. And they cannot detect any HIV in him. There are other cases where they did that procedure actually, and the virus rebounded. So every person that has gone into these clinical trials for HIV cure is very, very closely monitored to see whether actually the virus rebounds. And in fact, most people, the majority of people, the virus ends up rebounding. But there are these few cases that I mentioned where the individuals seem to have been completely cured because they can't detect virus. But in the fresh cohort, for example, we are following very closely those women who are undergoing that intervention, and we will see whether they either become cured or go into remission. I'm not at liberty to say at the moment because it's an ongoing study, but we are required, regulatory authorities, to very closely follow these individuals so that we can see what is happening, so that if the virus rebounds, they can be immediately put back on antiretroviral therapy.
Thank you, Dr. Nugu. So I know we're approaching the lunch hour, and I know you've had a lot of science in the last hour. So just, are there any final questions, or is there a final question from the group? Or can we release Tumbi to go have his lunch as well? Okay. Tumbi, thank you so much for all your support today. Thank you for joining us and being a fabulous speaker, taking us through cure strategies and answering all the questions. I see lots of nodding heads in the room, so I think some of the key messages have got through, so that's great. And I'm sure everyone will join me in giving you a huge round of applause.
Thank you very much, and thank you for the invitation. Hopefully I can be there in person next time.
Hope so too. So thank you, everybody. Thanks, Tumbi. We'll let you go now, and we will wrap up now for our lunch break. You've got an hour next door, as we were before. You've got meal tickets, I think, and then we'll be back in an hour for the workshop element of this workshop of this day. So enjoy your lunch.